Good morning, everyone. Do you see my screen?
Yes, I can see.
Okay. Yeah, so as Karthik said, we're going to speak about the activation clinical trial. This clinical trial was published in September this year in JACC Interventions. Just to give a background, as you all know, severe aortic stenosis is associated with adverse clinical outcomes, especially in the subset of the symptomatic patients and when it's left untreated. And one of the success stories over the last 15 years or so is the introduction of the transaortic valve interventions. And as you all know, this treatment, when it was compared to the standard of care, which is surgical aortic valve replacement in a randomized controlled fashion, it was shown to be non-inferior and in certain instances even superior to TAVR. And as we are performing TAVR more and more, one of the things that we are noticing is the prevalence of the coronary artery disease in this subset. What is the prevalence? It depends on what report you read. It goes anywhere between 40% to 70%. To the left, I'm showing you the Gary registry, which is the German aortic valve registry, which is a representative sample of about 16,000 patients, all comers, between 2011 and 2013. In their experience, they reported a prevalence of 55%. So it's one of the large registries that are out there, and they reported around 55%. But if you look at other registries, it can vary from 40% up to 70%. As for the randomized controlled trials, there is a wide variation in the prevalence of the coronary artery disease, and that is mainly a function of the inclusion criteria and the exclusion criteria of these clinical trials. The initial clinical trials included patients who had high risk or prohibitive risk by the STS score, and because of that, you can see that the prevalence of the coronary artery disease exceeded 70%. In the case of the core valve extreme risk clinical trial, it's almost reached 80%. But in the newer clinical trials, the Partner 3 and the Evolute low risk, you can see it's like, less than 20%. So as we are noticing the prevalence of the coronary artery disease, that raises many questions. The first thing is, what is the significance of this finding? Is there any effect on the patient's prognosis? And there are multiple observational studies that investigated this question. And if I want to simplify them, I can put them in one of three categories. Number one is studies which were able to find a significant association between coronary artery disease and adverse outcome in the patients who underwent TAVR. The second group, they couldn't find that association. And the third group is they couldn't find the association, but when they looked at the subset of the patients who had significant coronary artery disease, as defined as proximal epicardial vessels with stenosis more than 70%, or in the case of the left main, more than 50%, then in that subset, that is where, there is increase in the incidence of adverse events. And even when researching groups try to summarize the data to us in a form of meta-analyses, there is also conflicting results. So these are two meta-analyses that are cited in the literature. Both were reported within the last 3 years. And they both included the same studies. You can see the one to the left was published in Euro Intervention. And they looked at mortality at 1 year, and you can see the diamond over here is crossing 1, as in there's no difference between mortality in the patients who didn't have coronary artery disease versus the patients who had coronary artery disease. On the other side, on the right side, this meta-analysis explored the same question. This one was published in JAHA, the Journal of American Heart Association. Now we see the diamond is completely to the right of of the line associated with significant p-value, indicating worse outcome when there is presence of coronary artery disease in the patients who are undergoing TAVR. Now, the way that these conflicting findings were explained is, number one, there is the way that coronary artery disease was defined in these observational studies varied. Most of the studies just reported visual assessment of the coronaries. Only few of them reported QCA. Even fewer studies used physiological studies to assess coronary artery disease in this subset. The second thing is the way that the clinical outcomes were assessed were also not uniform. And this is how, these data are, explained. Now, the next question is, if we intervene on these patients, as in doing percutaneous coronary intervention, will we modify the possible or potential association between coronary artery disease and adverse outcomes? Many studies, start this question. I have to say all of these studies are observational studies, and many of them are single center experiences. But the totality of the evidence, we didn't notice evidence of harm with the use of PCI in the patients who had coronary artery disease in this subset. Having said that, when this question was approached from the angle of the completedness of the revascularization, as assessed by the residual syntax score, now here, some studies started to notice that patients who had higher residual syntax score, they were more likely to experience adverse clinical outcomes, such as MACE, such as mortality in this study. And here we started to notice increased adverse outcomes in some of the studies. Again, these studies are all observational. As for the guidelines, our valvular heart disease guidelines was recently updated in 2020. This is the ACC/AHA guidelines. The only two recommendations that we have is, number one, if a patient is assessed by structural heart team or valvular heart team and transaortic valve intervention was deemed possible and feasible, and the patient goes coronary angiography, if the patient has left main disease or proximal coronary artery disease, we have an indication for PCI prior to TAVR, and it's given a recommendation of 2A. If the patient was noted to have complex bifurcation left main and or multivessel disease with high syntax score exceeding 33, then probably the TAVR decision should be reassessed, and probably doing surgical aortic valve replacement and bypass procedure is the right thing to do by the patient. I just want to draw your attention to the table to the left. These two recommendations are associated with level of evidence C, LD for limited data to support these recommendations. So just to summarize what I told you already, is just we are noticing a high prevalence of coronary artery disease in the patients who are undergoing TAVR. And even though we have a couple of recommendations from the ACC/AHA, but as you see, so the recommendations rely on observational studies and only limited data. And the activation clinical trial is going to be the first clinical trial that is going to report its result in a randomized controlled fashion, assessing the use of PCI versus no PCI in the patients who are about to undergo aortic valve replacement transcutaneously. This study was investigator-led, prospective, randomized. It was open label, and it's a non-inferiority trial. It was performed at 17 centers in 3 European countries. All patients underwent heart team discussion prior to enrollment. And the inclusion criteria of this clinical trial was clearly the patient had to have severe aortic stenosis and it has to be suitable for TAVR. And the patient has to have at least one stenosis that was exceeding 70% in an epicardial artery that is deemed suitable for a PCI. In the case of the left main or a vein graft, they included patients who had stenosis more than 50%. The exclusion criteria: if the patient had acute coronary syndrome within 30 days of enrollment, those patients were excluded. If the patients had high Canadian classification of angina 3 or 4, those patients were excluded. If the patients had unprotected left main disease, those patients were excluded too. And clearly, patients who had medical conditions that prohibits them from receiving DAF, those patients were excluded in case they were randomized to the PCI arm, and then they will require DAF, so they excluded those patients. The randomization occurred in one-to-one fashion. This is an important point. Patients, investigators, and outcome assessors were unblinded to the treatment assignment. And the loading of the antiplatelet therapy was standard, like aspirin was 300, Plavix was 600, Efient was 60, and Brilinta was 180.
Hey, Mo, do you mind
Yes.
just commenting on when the patients were randomized at what point in the workup and procedure?
Yes. So I'm going to go over that when we get to the results, but
okay.
But
you can wait then. I don't want to steal your thunder.
okay, right. Yeah, so actually, like, it's gonna come over here too. So the primary endpoint of the clinical trial was a composite of all-cause mortality and rehospitalization from any cause at 1 year from the TAVR procedure. Okay, so just to remind everyone that the patients, if they were randomized to the PCI arm, they underwent the PCI pre-TAVR, and the randomization occurred before that, but they reported the primary outcome at 1 year after receiving the TAVR procedure. And clearly, the patient who weren't randomized to the PCI arm, so they didn't receive PCI, they went ahead with the TAVR, that's the starting point for them. Again, this study is a non-inferiority study, so they wanted to clear a safety non-inferiority margin of at least 7.5% at 1 year after receiving TAVR. Other endpoints that the study investigated was mortality, bleeding events, and MACE. They did their sample size calculations, and they felt they required 310 patients to achieve power of 90%. But unfortunately, this study was terminated early due to slow recruitment. And by the time that they randomized the last patient, they had a sample size of 235. And this is the scheme of the study. So 235 were enrolled. All of these patients were randomized. 119 went to the PCI arm. 116 were randomized to the no PCI arm. And a few patients were excluded at the 30-day mark, and a few patients were excluded at the 1 year mark. The most common reason for the exclusion was withdrawal of consent, or having one of the exclusion criteria, like a residence of so these patients were excluded. But in the end, we had a sample of 109 patients who underwent who were randomized to the PCI arm versus 102 patients who were randomized to the no PCI arm. The baseline characteristics between the two groups were relatively well balanced. There were no differences except for prior myocardial infarction was reported at around 12% in the PCI arm versus 23% in the no PCI arm. And the history of peripheral vascular disease was reported at 12% in the PCI arm versus 21% in the no PCI arms. Important baseline characteristics to alert you about is the mean age for the patients were like 83 to 84 years. The NYHA functional classification, almost 90% of the patients had NYHA classification of 2 and 3. The Canadian classification of angina, like, it was one of the inclusion-exclusion criteria, so almost all of the patients had class 0 to 2. The SDS score, the median was 4.4 in both groups. Just to remind you that the intermediate risk is between 4 to 8. Yeah, the angiographic characteristics of the study, the left anterior descending with a stenosis more than 70% was the most common vessel. It was reported at around 60% between the two groups. And within the patients who underwent PCI, almost 70% of the patients had just one vessel treated. The lesion length on average was 17 millimeters. Bare metal stent was used in 17% of the times, and there were only few complications related to the PCI procedure. The PCI procedure were relatively successful. The stenosis at baseline on average for the whole group was around 80%, and after the intervention was less than 5%. As for the TAVR procedure itself, 92% of the patients in both arms actually underwent the TAVR. The femoral access was the most common access used, and the Edwards sapien was used in 93% of the patients, as opposed to 88% of the patients in the no PCI arm. There were more complications related to the TAVR procedure in the PCI arm, reported at 14% compared to the no PCI arm, reported at 9.5%. So this is the Kaplan-Meier curves for the primary outcome. Again, just to remind everyone, the primary outcome was a composite of mortality and rehospitalization. The primary outcome is the graph to the left, and they started it at the time of receiving the TAVR. And you can see that the two lines, like, they are on top of each other. By the end of the procedure, like at the end of the clinical trial, the PCI arm had an absolute difference of negative 2.5%. Having said that, the study couldn't conclude that PCI was non-inferior to no PCI because they couldn't clear the 7.5 safety margin. When they did the analysis, it was at 8.5. And this graph to the right just goes to what Dr. Capel was asking me. They repeated the analyses, and they used a different starting point. They used the starting point at the time of the randomization, not at the time of receiving TAVR. And again, they were able to show similar results. Now, this is analyzed as an intention to treat analysis. The clinical trial also reported their results in a per protocol analysis. They didn't show a graphical representation of it, but the patients who didn't receive the TAVR were excluded. Some of the patients who were randomized to the PCI arm and didn't undergo PCI were included with the no PCI arm, and then they performed the per protocol analysis. And in the per protocol analysis, the results shifted a little bit in favor of the PCI. And the primary outcome was reported at 40% in the PCI arm, as opposed to 45% in the no PCI arm. And in that per protocol analysis, they were able to clear the safety margin of the 7.5. And it was associated with a p-value of 0.050. This table goes over the secondary outcomes. And the secondary outcomes were analyzed at 30 days and at 1 year. So at 30 days, MACE were no different between the two arms, and the rehospitalization rate was also no different between the two arms. AKI at 30 days was higher in the PCI arm, but that did not reach statistical significance. Also, the bleeding events were higher in the PCI arm, compared to the no PCI arm, 41% compared to 26%, but this didn't reach statistical significance. When they reassessed these outcomes at 1 year, again, MACE, rehospitalization, and AKI did not reach statistical significance. There was no difference between the two groups. It's in the bleeding events, any bleeding was higher in the PCI arm compared to the no PCI arm, and this time was associated with a p-value of 4.02. I just want to draw your attention that the vast majority of the bleeding events occurred within the first 30 days. So out of these 53 events, 49 of them occurred within the first 30 days.
Check the lab.
I need my steps.
Guys, if you're not talking,
There were two, right?
we're supposed to mute yourself.
Oh, he's here. Okay, but he's starting at.
Can you guys mute?
So out of the 53 any bleeding event that occurred in the PCI arm, 49% of them occurred within the first 30 days, and out of the 31 major bleeding, every single one of them occurred within the first 30 days. This is like the distribution of the antiplatelet and anticoagulants that was used in this clinical trial. And before randomization, patients who were randomized to the PCI arm were more likely to be on vitamin K inhibitor or DAPT compared to the no PCI arm. And clearly after the provision of the PCI, you can see that the patients who were on DAPT, like there's almost like 30-point difference. But by the time that we get to the end of the clinical trial, the difference was like, slight. But this is important because it goes back to the bleeding events. As I showed you that most of the bleeding events occurred within the first 30 days, and the proportion of the patients who were on DAPT and triple therapy in the PCI arm within that time period was higher compared to the no PCI arm. So it is an important explanation why the bleeding events were higher. Now, just to summarize the findings, we didn't find difference in the primary endpoint between the PCI arm and no PCI arm at 1 year. And when we analyze the data when we analyze the data, like, in intention to treat fashion, like we weren't able to clear the safety margin of the 7.5% that was pre-specified by the clinical trial. So we weren't able to conclude non-inferiority. Having said that, like, when the per protocol analysis was performed, that analysis, like, was able to do it. The secondary endpoints, there was no difference between the two arms when it comes to MACE and rehospitalization at 30 days and 1 year. And there was high rates of bleeding, any type of bleeding in the PCI arm compared to no PCI arm, but that may be related to the higher use of the dual antiplatelet therapy. Few limitations of this clinical trial. Again, as I told you, this clinical trial was terminated early. They recruited 235, even though they were hoping that they can recruit 310. The follow-up is still short. It's only 1 year. Probably if we follow those, like, people like the proponents of the use of PCI, they believe if we follow them longer in time, probably, like, we can find a signal of benefit. This clinical trial was not blinded. This clinical trial, we cannot extrapolate its results to patients who have unprotected left main or Canadian classification of angina of 3 or 4. And again, the way that the coronary artery disease was assessed, no physiological assessment was taken. Just before I open it to questions and discussions and teaching points, I just want to say that the activation clinical trial is first of many randomized controlled trials to come. We have 6 randomized controlled trials that are slated to report their results within the next 2 years, investigating the same question, and some of them are refining their methodology using FFR in 5 of these 6 clinical trials. They should report their outcomes in 2022, 2023. This figure comes from the accompanying editorial to this clinical trial, and the 2 physicians who wrote this editorial, based on their expert opinion, this is some of the things that they consider before, like, they give patients like PCI prior to TAVR. And the things that they gave most weight to is whether the patient has like long life expectancy, the degree of the stenosis of the coronary artery disease. Then the third thing was like, whether the patient had high risk of bleeding. And the last thing that they consider is whether they were going to be able to access the coronary with ease after the provision of the aortic valve. This also like a state-of-the-art review article, which was published last month, with a similar algorithm. This one, like we have 2 physicians from our group, Dr. Forrest and Dr. Lansky, like, were involved in this study. They also like, give their expert opinion in respect of who should get pre-TAVR PCI, and what are the things that makes you like, make that decision. So I'll share these 2 articles with the fellows. Like, I thought that it was good articles to read. So I'm going to stop over here, and any comments, any teaching points or questions?
So Mo, that was a great job. Just for the group to give a little bit of a background, and I think one of the things everyone may not be aware of is that while with TAVR, we for the longest time gave patients dual antiplatelets. There's been a lot of data that's come out that has suggested that post-TAVR dual antiplatelets are quite harmful, and that patients do much, much better with single antiplatelets. And so I think a lot of what sort of is driving this question is the recognition that, dual antiplatelets in 80-plus-year-old patients are not good, and we still give dual antiplatelets after PCI. And so I think this shows that, that dual antiplatelet strategy leads to more bleeding complications than you would get with just a TAVR with single antiplatelets. And the balance of those increased bleeding complications versus the having revascularized the patients is sort of really what's being compared here. I think it's also important to note in the study that this was a study where the patients were only included if they thought there was equipoise, right? So this wasn't all patients who have coronary disease. So if you had a CTO or a ridiculously heavily calcified bifurcation of your circ in a marginal branch or a distal LAD, and the operator didn't want to have to intervene upon that patient didn't get into this study. Similarly, if you had a 95% type A lesion of the proximal RCA or the proximal circ, that patient also didn't get into this study because they just did the intervention for that patient. So I think it's important to note that you can't take these results and apply them to all patients who are having who have coronary disease after their diagnostic cath. But I think it does point out that leaving coronary disease behind has become more and more of a stable of for patients who have severe symptomatic aortic stenosis. And the reason this study couldn't enroll patients is because that's become more and more accepted. And sort of, I think people sort of feel, certainly in Europe, I know which ones to treat and which not to. And Europe always has a bit of a challenge enrolling in randomized studies like this, although, as you mentioned, there are a bunch of ongoing studies.
Yeah, totally agreed. Like, just to piggyback on what Dr. Forrest was saying, like, this wasn't like all comers, like all patients were screened by a heart team before like any intervention was undertaken. And, as Dr. Forrest said, like, only the ones that were like, felt to be like, more straightforward, like, they didn't attempt like any PCIs on patients with like, complex disease. And you saw the results, like, the average was like 17 millimeters, like, yeah.
Yeah, excellent presentation, Mo, and I agree with all the points that that John makes over here. And obviously, this is a non-inferiority trial, which is what we see a lot these days. Important to also highlight that they had two types of analyses of the composite endpoint, and they do the win ratio analysis as well. And you might notice more of that in trials, because not all portions of the composite endpoint are considered clinically equal, right? So cardiovascular death is obviously of much more consequence than other non-fatal outcomes. So this sort of tests it in a hierarchical manner. But obviously they were not able to achieve the non-inferiority because of poor enrollment due to the reasons that John highlighted. And but I think one important thing to see was obviously the heterogeneity in DAPT and anticoagulation use, again, as John points out, and no clear recommendations at this time, and need for more data as to how to manage these patients, after TAVR as well. But clearly there was more bleeding events because of the need for DAPT after PCI. There's one thing that it doesn't obviously evaluate is, coronary access after TAVR, and that is one thing that is a concern that is raised, and one of the cases that is made for TAVR. Obviously, that's not analyzed in the study, but what do the structural folks think about that? And is that anything that should factor into PCI decisions?
Yeah,
Yeah, so go ahead, Ryan.
Yeah, just to comment on that. It's a good question. I mean, it's always part of our calculus. I think we always get a CT scan before the patient goes to the cath lab if we decide they need to go to the cath lab, partly because we can look at the coronaries in some of these patients and decide if they do need a cath, and we're utilizing that more often now. But if as I think everyone knows, John gave a great talk on coronary access after TAVR, and the balloon expandable SAPIEN platform just makes it easier to get to the coronaries, of course. And so we do include it in our decision about how which valve to use. I think we may be more, if we have to use an Evolute, the self-expanding valve, because of a small annulus, for instance, we may be more inclined to fix some coronary disease beforehand because the reaccess is more challenging. And the age of the patient plays into that. Certainly, I think that flow chart that Mo showed with the life expectancy of 5 years, we don't like to do TAVR on people with a life expectancy less than 1 or 2 years. But if they have a lot of years ahead of them and it's a self-expanding valve, we may want to intervene ahead of time. But it does play a part in what our decision, certainly.
And I guess just the other thing that I would add is, to Ryan's point, there's a tremendous amount of sort of thought around that goes into, should we PCI, what valve should go in, what's it going to be afterwards. Our group is a little unique as compared to others in that, we to share volume and to share other things. Every interventional cardiologist, I suspect, is doing caths on pre-TAVR patients. At a lot of places, it's just the people who are doing the TAVRs who are doing the pre-TAVR caths. And so I think it's important. I think it's great that everyone does it, but it's also critically important that there's communication around what's going on and discussions before stents go in. We have had patients where that discussion doesn't take place and the patient ends up getting a stent when really it probably they needed surgery or they needed other things. And so the last thing I would say is just to please make sure, we try to do a good job documenting in our notes and then other documentation about what the plan is around the time of cath, but we don't always get to that. One of us may have seen the patient, another one may have reviewed the CT scan. I think when you're doing a cath on a pre-TAVR patient and there is coronary disease in a question, please reach out to whoever's on call, call me or whoever is the structural attending for that day to review the case before proceeding with the PCI. I think, the data here is clear that there should be a thought process around it. And that would be sort of the one thing that I would ask of the group. And it happens almost all of the time, but we have new fellows and new faculty. And so I think reiterating that is always beneficial.
That's great. I don't see any questions in the chat. Does anybody have any other questions? All right, hearing none, we'll give 20 minutes of time back to everybody else. Thanks, Mo. That was a great presentation.
Thank you very much, everyone.
Well done.